Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Hello and welcome. In this explainer, we're going to build a solid framework for understanding the pharmacology of congestive heart failure. The goal here is to get way beyond just memorizing drug names. We're going to connect how these drugs work directly to the underlying disease process, so you can really master this stuff for your clinical exams. Let's dive in. So here's our game plan. First, we have to understand the fundamental problem, the pathophysiology of a failing heart. Once we get that down, we'll systematically look at our drug targets. We'll start with drugs that tackle volume and pressure, then move to the ones that block those harmful neurohormonal signals. After that, we'll touch on some special agents, the inotropes, before tying it all together with a practical, stage-by-stage treatment strategy. All right, first things first. Before we can even talk about fixing the problem, we have to understand it, right? This section is absolutely the foundation for everything that follows. If you can master the why of heart failure, the what and how of the drugs we use will make perfect sense. So what is congestive heart failure really? At its core, it's a pump problem. The heart just can't move enough blood to keep up with what the body needs. And this failure can come from one of two issues, either a problem with squeezing the blood out or a problem with relaxing to let blood in. Now, here's a really critical distinction you've got to know for your exams, and it's all about the ejection fraction. We split heart failure into two main types. On one side, you have HF or REF, or heart failure with a reduced ejection fraction. This is your classic systolic failure. The heart muscle is weak and can't squeeze hard enough. On the other side is HFpEF with a preserved ejection fraction. This is diastolic failure. The ventricle isn't weak, it's just stiff and can't relax properly to fill with blood. This really matters because most of our evidence-based, life-saving therapies are targeted at HF or REF. Okay, take a good look at this flowchart. I want you to think of this as our roadmap for the entire talk. It all starts at the top with that one central problem, decreased cardiac output. This one problem kicks off a whole chain reaction of what the body thinks are helpful responses, but in the long run, these compensatory mechanisms create a terrible, self-perpetuating vicious cycle that just makes the heart failure worse. So let's follow the arrows on our map. When the body senses low cardiac output, it basically panics. It calls in the big guns, the renin, angiotensin, aldosterone system, you know it as RAS, and the sympathetic nervous system. Together, they clamp down on blood vessels to keep pressure up and tell the kidneys to hang on to every last drop of salt and water. But all this does is crank up the workload, both the filling pressure, or preload, and the pumping pressure, or afterload, on a heart that's already struggling. These two systems are the main villains of our story, and they're the primary targets for our most important drugs. Okay, so our first line of attack has to be managing the immediate fallout from this maladaptive response. We've got to relieve that overwhelming volume and pressure that's crushing the heart. These drugs are all about providing symptom relief, helping the patient who can't breathe or has swollen legs feel better fast. And the number one tool for managing that excess volume? Diuretics. If you look back at our map, diuretics hit that salt and water retention box head on. By forcing the kidneys to get rid of more salt and water, they reduce the total amount of fluid in the body. This directly lowers the filling pressure in the heart, the preload, and gives patients quick relief from symptoms like shortness of breath and swelling. Now, not all diuretics are created equal, and for your exams, you need to know the difference. For a mild case, a thiazide diuretic might be enough, but when you have a patient who is significantly fluid overloaded, you have to bring out the heavy hitter, a loop diuretic like furosemide. Here's why they're so potent. They work in a part of the kidney, the thick ascending limb, that's responsible for reabsorbing a huge chunk of sodium. So blocking it really gets a lot of fluid off. And finally, don't forget the case-sparing diuretics, specifically spironolactone. Yes, it's a weak diuretic, but its real superpower is blocking aldosterone, which not only gets some fluid off, but also has been proven to help people live longer. All right, next up, we're going after that intense vasoconstriction that's squeezing the life out of the heart. The idea behind vasodilators is simple. Relax the blood vessels to take the pressure off the pump. And we can be strategic about it, targeting either the veins to reduce filling pressure or preload, or targeting the arteries to reduce the resistance the heart has to pump against, the afterload. So we can tailor our approach pretty well. Venodilators, like nitrates, are great at opening up the veins. This lets more blood pool in the periphery so less of it rushes back to the heart. That lowers preload and is fantastic for relieving that backed up feeling of pulmonary congestion. On the flip side,
arterial vasodilators like hydralazine relax the arteries, lowering systemic resistance. That drops the afterload, making it way easier for the weak heart to pump blood forward, which boosts cardiac output. And here's a super high-yield fact for exams. The combination of hydralazine and isosorbide dinitrate is a big deal, especially for African American patients with HFrEF, as it's been shown to improve survival.
Okay, so we've managed the symptoms with diuretics and vasodilators, but that's like bailing water out of a sinking boat without plugging the hole. To actually improve long-term survival and stop the disease from getting worse, we have to go after the source of the problem, that chronic, damaging neurohormonal activation. These are the real disease-modifying cornerstone therapies.
The absolute bedrock of HFrEF therapy is the ACE inhibitor class. The classic prototype drug you'll see everywhere is lisinopril. And remember, when you see a question on your exam about lisinopril, they're not just asking about one drug. They're really testing your knowledge of the entire ACE inhibitor class, from how they work to their side effects.
Let's go right back to our map. ACE inhibitors throw a giant wrench right into that RAS machine. They block the enzyme that converts angiotensin 1 into the super potent angiotensin 2. By shutting down angiotensin 2, you get multiple huge benefits. First, you block its intense vasoconstriction, so blood vessels relax and afterload drops. Second, you cut way down on aldosterone secretion, which means less salt and water retention, so preload drops. The bottom line? It's much less work for the heart, which over time allows it to heal and remodel in a positive way. Now for our second cornerstone therapy, beta blockers. And I know what you might be thinking. This feels totally backwards, right? Why on earth would you give a drug that can weaken the heart's contraction to a patient who already has a weak heart? Well, the key is to think long-term. They work by protecting the heart from the toxic, damaging effects of being constantly flogged by adrenaline and other catecholamines. The key prototypes here are metoprolol succinate, carvedilol, and bisoprolol.
So beta blockers work by blocking those beta-1 receptors in the heart. This basically puts a shield up against the sympathetic nervous system, which calms everything down. It lowers the heart rate, reduces the force of contraction a bit, and lowers blood pressure. All of this decreases how much oxygen the heart needs. But here is a massive, must-know clinical pearl for your exams. Never start a beta blocker in a patient who is in acute decompensated heart failure. They are unstable, and giving a drug that weakens the pump, even a little, can be a recipe for disaster.
All right, let's shift gears and talk about a class of drugs that does the exact opposite. These are agents that directly increase the force of the heart's contraction, or what we call positive inotropy. We generally save these for patients with really severe heart failure, or in emergencies when we need to boost cardiac output right away. The classic oral positive inotrope is digoxin. Now, this is an old-school drug for sure, and we use it a lot less now that we have safer options. But its totally unique mechanism and its potential for toxicity make it a favorite topic on clinical exams.
The way digoxin works is pretty cool and very specific. It actually poisons the sodium-potassium pump on heart muscle cells. This causes sodium to build up inside the cell. Because there's so much sodium inside, another exchanger that normally kicks calcium out can't work as well. The end result? Calcium builds up inside the cell. And more calcium available to the muscle fibers means a stronger squeeze. Today, its main use is for HFEF patients who are still having symptoms despite being on all the right meds, especially if they also have atrial fibrillation, because digoxin has a nice side effect of slowing the heart rate in AFib.
Okay, we've covered all the major drug classes. Now, let's put it all together into a strategy that actually makes sense in the clinic. To do this, we'll use the American Heart Association's staging system, which is a great way to think about how the disease progresses.
First up is stage A. And the key here is, this isn't actually heart failure yet. This stage is for people who are at high risk because of things like high blood pressure, diabetes, or coronary artery disease. So the treatment is simple. Prevention, prevention, prevention. We aggressively manage those risk factors to stop heart disease from ever developing in the first place.
Now, in stage B, things have progressed a bit. There's actual structural damage to the heart, like a low ejection fraction after a heart attack. But, and this is the crucial part, the patient feels perfectly fine. They have no symptoms. This is our golden opportunity to intervene. For patients with a low ejection fraction, we start them on our cornerstone therapies, an ACE inhibitor and a beta blocker, to prevent that heart from getting worse and delay the start of symptoms for as long as possible.
Stage C is what most people think of when they hear heart failure. The patient has both the heart damage and they have symptoms, either right now or in the past. So here, we pull out all the stops. We use diuretics as needed to control their fluid and keep them comfortable. We absolutely continue those life-saving ACE inhibitors and beta blockers. And then we start layering on other evidence-based therapies, like spironolactone or even newer agents, to improve their symptoms and help them live longer.
So, we've laid out this whole framework based on the therapies that have been the foundation of treatment for decades. But here's the thing, this field is changing fast. We have these amazing new drug classes like SGLT2 inhibitors and ARNIs that are really changing the game, which leads to a really interesting question for the future. As these powerful new agents become the standard of care, which of these classic foundational drugs we just talked about, like ACE inhibitors, might actually get bumped down to second-line therapy in the next 10 years? Something to think about.